Hello everyone. This is SM Abdullah, a member in Health Economics Research Network and fellow in ARK Foundation. I appreciate all your kind presence despite the busy schedule. On the capacity building front under the umbrella of HERN, this is the regular webinar arranged by this network in collaboration with Center of Health Economics, University of York, UK. Today, we have the honor of the presence of Dr. Mark Scalfer, Professor and Director of the Center of Health Economics, University of York, as our distinguished speaker. Besides, we also have the privilege to present Dr. Simon Walker from Center of Health Economics, University of York. Mark has worked extensively on economic evaluations of a range of technologies, including heart disease and various cancers. Additionally, he contributed to methods in the field, in particular, relating to decision analytic modeling and handling uncertainty. With extensive number of peer-reviewed publications, Mark is also the co-author of two major textbooks in the field. Namely Methods for the Economic Evaluation of Healthcare Program and Decision Modeling for Health Economic Evaluation. We have firm belief that today's session is going to be thought-provoking and will generate much more interest in the early career researchers and the mid-career researchers who would like to do some contribution and do some research work in this field of economic evaluation. So without wasting much time, I would like to invite our honorable guest today to present his lecture. We would like to also request our participant to keep their microphone muted for smooth progress. Thank you so much for participating. And now I would like to welcome Dr. Mark Scalfer to present his speech. Thank you.
Thank you very much, Abdullah. It's a great pleasure to be here. I'm going to just share my slides now. Well, simple title, Introduction to Economic Evaluation. This is, since I've been working in the field, the toolkit of economic evaluation, as well as the list of applications has grown enormously. And so this is a big topic. And so you should think about this as very much an introduction. And if you're interested in it, it's worth trying to progress your learning in this area. Just want to say something to start with about the Center for Health Economics at the University of York, which I direct, our commitment to capability building in health economics, and particularly in low and middle income countries. We're certainly committed to support this network, the Bangladesh Health Economics Network, and we're very happy to do that through the National Institute for Health and Care Research in the UK, and particularly through the DiaDem project. But we also have involvement more generally in capability building in health economics through the Global Health Economics Network. So that's part of the Global Health Network. If you take a look at that link, you'll see that we've provided with collaborators a range of open, free to view resources in training and teaching of health economics. So you may find that helpful as well. And the last thing I want to mention is that we will have the pleasure of welcoming 5 candidates from the South Asia region to begin a 3-year program of distance learning at master's level in health economics. So they are very shortly to begin that course. We're looking forward to welcoming them. So just to get on to the topic in hand, you'll probably be aware, many of you, that the World Health Organization back in 2000 laid out 4 key functions of healthcare systems, namely to generate revenue, to provide a pooling of revenue across a collective population, to purchase and to provide healthcare, and to offer stewardship of relevant healthcare systems. In the context of this lecture on economic evaluation, essentially this relates to item 3 here, about purchasing the right types of healthcare and providing the most appropriate types of interventions and policies. But the methods of economic evaluation have relevance to all of those 4 elements, because by understanding the value of the services and interventions that systems ultimately offer, it tells us something about other aspects, the other aspects listed here. So hopefully that will become clearer as we progress through the talk. Sorry, a couple of other bullet points that just make that last point. So this is a sort of, if you like, a 101 framework of analysis in thinking about what economic evaluation is trying to do. We need to think about there being some objective of healthcare. Now, the way we generally shorthand think about this is that health systems are trying to maximize something. And the most obvious thing they're trying to maximize is the health of their population. In reality, of course, health systems have all kinds of objectives. One would imagine that trying to improve the health of the population for which they're responsible is a fairly central part of that objective. And so economic evaluation, in telling us something about the extent to which particular interventions, treatments, tests, policies contribute to increasing population health, that becomes an extremely important part of the evidence base for decision making. And all systems internationally, whether they be in high, middle, or low income settings, are constrained in the funding they have available. These constraints may not be explicitly defined as budgets. For example, in the US, many parts of their system, they would say they don't have budget constraints, but they do have limits on the amount of money that can be spent on healthcare. In other words, these constraints can come in different forms in different systems. And because of those constraints, the things that health systems are trying to deliver, the numerous things they're trying to deliver, for example, non-communicable disease care, maternal and child health, public health and prevention, improving the system itself, so through different types of system strengthening, all of those many things have to be contained within the constraints on expenditure. Which means that when we are thinking about new ways of delivering care, these could be new treatments, they could be new types of system strengthening, they could be new public health programs. We do need to understand how those new policies and interventions affect the thing we're interested in, which is population health, but also whether they will actually generate savings financial from a resource cost perspective, or whether those new interventions will actually add to costs. Because if they are additional to cost, then because of the constraints on the health system, that means that other things are displaced. If you've got constrained healthcare because of either a budget or other or similar constraints, when you're delivering something new that costs more, you have to take something away from some other aspect of healthcare, either constraining the use of other interventions or ending the use of some treatments or interventions in order to make the financial room for whatever this new intervention is. And the benefits that are displaced, which we call opportunity costs, are absolutely fundamental to how we think about economic evaluation. And ultimately, within this sort of simplified framework, the challenge is to establish whether the new intervention or policy or health system strengthening we expect to result in a net gain in population health. In other words, is the health benefit associated with this new activity going to be greater than the opportunity cost, greater than the things we have to give up to accommodate the new intervention if it is adding cost to the system? So that's the sort of basic framework but we also have to think about how we define the question. Economic evaluation is a form of research. When we do research, we have to be very clear about what the research question is. And we often define that in economic evaluation as the decision problem. And there are three elements to this. What is the intervention we're interested in? What is the comparators? What are the comparators to that intervention? So what are the other ways we could manage this particular situation, these patients or potential patients? What are the other things we could do for this particular patient group? And then there is the population that we are interested in. So, for example, this might be the management of acute tuberculosis in a particular population. So this, we might define this as a pediatric population. So we're defining it partly by age. It could be partly by severity of the disease. So that's our population. We might have a new drug treatment that we are considering funding. That's our intervention. And the intensity of that intervention might be defined in terms of how often that's provided and for how long. We might need to say something about who administers the drug and who determines which patients receive it. But then there are the comparators as well, which is, well, how are these patients currently treated within the system? Are there alternative types of routine use? So there may be more than one drug therapy available. There may be some non-drug therapies available. And exactly how those therapies are administered, for example, are they in sequences? Do you try one drug first, and if it fails, you try another? And are there starting and stopping rules? When do you determine whether a drug has worked or not? So all of these considerations are part of defining the decision problem, which is an important precursor to doing any piece of economic evaluation. So I've talked about this idea of net health benefits being crucial to what we mean by doing economic evaluation. And anybody who has a clinical background will understand the concept of net clinical benefit. When clinicians, for example, administer a drug, a pharmaceutical, they are aware that treatment will have some intended effects. That is, the benefits that we're hoping accrue clinically to the patient as a result of the drug. But a clinician is also aware that drugs and other types of treatments as well can have unintended effects, side effects. So the intended effects improve the health of the average patient, but we have to recognize that unintended side effects actually reduce the health of the patient. And there is always a judgment call about whether the net clinical benefit is positive or negative, and clinical choices about identifying the right treatment for the patient presenting is very often about making sure that the expected net clinical benefit, that is the average effect for a given patient, based on their characteristics and based on knowledge of the treatment, are positive. When we think about economic evaluation, we just take that essentially a step further. We talk about the intended effects of a new treatment. So this is most easily understood in terms of, for example, drug therapy or a surgical procedure, but it extends to many other things as well, including prevention and system strengthening. But there are potentially unintended effects that have negative health implications for patients, as I've just said. But if this treatment also adds to costs in the healthcare system, then it will have opportunity costs because of the constraints on funding, meaning that if we spend more money on one treatment, we have to take money away from other things. which will affect the health of those individuals who were to consume those other things. So if this is a drug for tuberculosis, for example, and we are administering a more expensive drug than we currently provide, then we're going to have to find the money for that by doing less of other things. That could be less prevention work. It could be less effective management of pregnancy and neonatal care. So there are health effects which are negative as a result of that, and that's our opportunity costs. So when we're thinking about cost effectiveness or the value of a treatment or an intervention, we have to establish whether the net health benefit is negative or positive. So this is the net clinical effects plus any opportunity costs. So here we are, the net health benefit is negative. In other words, this particular intervention or treatment is not cost effective because the net clinical benefit plus the opportunity costs are negative. And therefore, there's no basis for this particular healthcare system to use this intervention. The key thing is, though, the opportunity cost will vary significantly by healthcare system. For example, in a relatively low income setting, where the financial constraints, the budget constraints, if you like, are much more severe, then if we are considering funding a new treatment for a particular patient group, and any additional costs of that new treatment will have more significant opportunity costs in low income settings because the constraint on the budget is more severe. In another setting, that same intervention might have much lower opportunity costs, such that overall there is a positive net health benefit, and we can conclude that intervention is cost effective and worth funding in the system. So we'll come back to opportunity cost later because it is so fundamental, and it will vary so significantly across different healthcare systems. This is a very popular way of thinking about this concept of cost effectiveness or value for money. Here we can think about a new treatment potentially replacing an old treatment. Very often, in reality, we're talking about a new treatment or a new investment of other types, prevention, system strengthening, replacing a whole host of existing ways of managing patients and potential patients. But let's keep it simple. New treatment replacing an old treatment. So we've got 4 quadrants here defined. They're defined because on the horizontal axis, we think about the effectiveness of the new treatment compared to the old. So compared to the origin, which is, if you like, that's the old treatment, to the right of the origin, the new treatment is more effective. To the left of the origin, the new treatment is less effective than the old treatment. On the vertical axis, above the origin, the new treatment is more costly than the old treatment. And below the origin, the new treatment is less costly than the old treatment. So we have 4 quadrants defined by those 2 axes, the cost axis and the effectiveness axis. So down here in the bottom right-hand quadrant, the new treatment is both more effective than the existing treatment and less costly. And when we think about cost here, we're not just thinking about a price of a drug, we're thinking about the overall impact on costs faced by the health system. So in this bottom right-hand quadrant, we say that the new treatment dominates because if this evidence about effectiveness and cost is reliable, then we can think about this as we say in England, as a no-brainer. It's obviously cost-effective and worth funding because it actually improves patients' health because it's more effective than the old treatment, and it saves us money because it's less costly overall than the new treatment, than the old treatment. And we would ask there about, well, what are the magnitude of the health benefits that the treatment provides? But also we get health benefits generated from the savings that this less costly new treatment offers. Conversely, in the top left-hand quadrant, the old treatment dominates because the new treatment is less effective and it's more costly. So there is no reason to, if we believe this evidence, there's no reason why we would want to fund a new treatment, because it's both generating less health for patients compared to the old treatment, and it's costing us more. So we would want to think about, again, compared to investing in a new treatment, we're actually making savings. But the key thing is that our budget remains intact because we're not funding the new treatment. And then we have two more difficult quadrants. We have the top right-hand quadrant, where the new treatment is more costly and more effective. And we have the bottom left-hand quadrant, where the new treatment is less costly and less effective. In these two quadrants, we can't say anywhere near as clearly and unequivocally as we could for the other two quadrants whether this new treatment is worth spending money on or not, because we have trade-offs in these two quadrants. The top quadrant, top right-hand quadrant, is a very typical situation where we have a new treatment, often a proprietary drug, by which I mean a drug that has a patent. It has a manufacturer who is seeking to recover a return on their research and development investment. So the price is going to be as high as they believe they can charge in a healthcare system. But the hope is that they have generated sufficient evidence to indicate that that new drug is more effective than the existing or old treatment. So we have to understand in this quadrant what other benefits could have been generated if we were to spend the same additional amount of money on other things. So this new drug offers benefits, but because we're going to have to spend more money on it compared to what we currently spend on these patients, then we need to know what health benefits we are going to be foregoing for other patients. Similarly, in the bottom left-hand quadrant, if you like, if we keep the old treatment, we're having to spend more for a more effective treatment because the new treatment is less effective and less costly. So we could move to the new treatment, generate savings, which we can spend on other patients and improve their health. But we have to compare that against the health reduction that the new treatment will generate because it's less effective than what we currently use. So this approach, this way of thinking about the costs and benefits of new investments compared to existing ways that we manage patients and health systems lead to some obvious questions. What outcomes are we interested in? What ones are relevant? What costs are relevant? And how do we make decisions in that top right and bottom left quadrant where we have clear trade-offs? So let's think about benefits first. As I said earlier, really in any healthcare system, there are a range of considerations regarding why we spend money. There are a whole range of objectives. These could include reducing health inequalities. These could be encouraging domestic manufacturers and developers of health technologies. This could be reducing financial burden on families. So in reality, what we call the objective function will be complex. Most economic evaluations start at least from a very simple objective function, and that is health improvement, health outcome. And that itself is going to be made up of survival duration, so the amount of time on an average that somebody's going to live. And secondly, their quality of life, the health-related quality of life, the things that, other than mortality, that people individually worry about in terms of their health, things like pain, their ability to be mobile, their ability to look after themselves, their family, and to be productive in the labor market, all of these things that matter to patients. And one measure, popular measure of health that brings both of those things together is the so-called quality adjusted life year, or QALY. And this diagram shows how we derive a QALY in very simple terms. Here we've got on the y-axis somebody's quality of life, the average patient's quality of life. And that's measured on a scale that runs from 0, which is equivalent to death, and 1, which is equivalent to full health. On the x-axis, this reflects patients' life expectancy in years. And we've got here two very stylized prognoses for patients. The yellow line is a patient's prognosis without treatment, and the red dotted line is their prognosis with treatment. So if you think about, to start with, their prognosis without treatment, patients' quality of life to start with is 0.7 on the 0 to 1 scale. After about a year, it declines to 0.6. After 3 years, it declines again to 0.4, and then it continues to decline until the average patient dies after 8 years. Contrast that with their prognosis with treatment, the red dotted line. They too are identical to start with. They start at 0.7. To start with, the treatment itself, through side effects perhaps, might reduce quality of life. And that reduction exists up until a year, after which it improves to 0.6, then it improves again after 2 years to 0.7, it's improved to 0.8 after 3 years, and again to 0.9 on the scale after 4 years. And the patient, the average patient, continues at 0.9, quite relatively high quality of life, until they also die on average after 8 years. So the first thing to note about this comparison of prognoses, average patients with and without treatment, is that there is no extension in life expectancy from treatment. Patients on average die at the same point in time. However, once patients recover from the side effects of treatment, they get a big gain in quality of life as a result of treatment. So in thinking about this measure, the QALY, the quality adjusted life year, all we're doing is we are quality adjusting periods of time. So without treatment, the number of QALYs associated with that prognosis is the area under the yellow curve here. So all we're doing is multiplying periods of time in years by the relevant quality adjusted life year weight, which is the 0 to 1 scale. And similarly for the prognosis with treatment is the area under the red dotted line. So the area A minus the area B is the difference to prognosis curves. And that is the QALYs gained associated with treatment compared to no treatment. So all we're doing with a QALY is partitioning the average patient's life expectancy into smaller chunks and weighting those chunks by the relevant measure of quality of life. But this measure of quality of life has to mean something. We have to understand something about preferences associated with quality of life. So, for example, if this was treatment for tuberculosis, how bad are the side effects associated with this treatment and this particular drug? And how would patients put value on those on the 0 to 1 scale? Or indeed, how would the average member of the public put a weight on those side effects on the scale? And similarly, once side effects are recovered from and a patient's health improves, how would the patients or the public put a preference weight, one of these values, to the improved quality of life over time and to the worsening quality of life over time? So we have to generate that type of evidence. Now, the QALY is widely used particularly in high income settings, but also in low income settings as well. But there is another measure called the disability adjusted life year, the DALY, which is also used quite widely, particularly in studies and research that has been funded by or organized by the World Health Organization. But conceptually, the QALY and the DALY are very similar. But strictly, the DALY is more a measure of overall disease burden. But once you've measured or estimated the DALY for existing treatment and for a new treatment, the difference in those two measures of disease burden is also a way of expressing the benefit of the new treatment. So DALYs can be used in exactly the same way as QALYs. Conceptually, what we're saying with the DALY is that we are partitioning people's prognosis again according to the years they live with disability. So that it's how long they live with some level of quality of life that is less than full. And that's part of the partition. And we're also thinking about the years of life lost. So that is, how many years of life do they lose because of premature death? And we put those two things together, the years lived with disability and the years of life lost, to get our DALY. It's another way of looking at it, and this looks now very similar to the diagram for the QALY. Essentially, we can think about quality of life as on the x-axis again at 100% or 0, and we can think about somebody's full life expectancy being 20 years. But with a particular disease, that disease under current treatment might reduce quality of life down to, say, 40%, and it might reduce their length of life for the average patient from 20 years down to 10. So we can think about the years of life lost as being associated with that reduction of 10 years in life expectancy. But we've also got the disability years, if you like, the years living with disability. That's 10 years with a reduction in quality of life down to 40%. So those two areas, the years living with disability and the years of life lost, represent the DALYs foregone, or the DALYs lost associated with this disease under current treatment. And we could compare the DALYs lost under a new treatment as well, and that will be entirely analogous to our changing quality adjusted life years. Should we be using DALYs or QALYs? Well, they're very similar, and in principle, one shouldn't get wildly different results whether one's using QALYs or DALYs. QALYs are probably more bespoke to individual countries than DALIs. That is a bit more generalized and driven by the need for international consistency and data availability. There are other complexities with DALIs that you can include age weighting. So if you think health is more important at different age groups, then you can include some age weighting. DALIs tend to be much more widely used if you're participating in an international project, for example, with WHO or World Bank. And QALYs tend to be used more if you have available data within your country. Right, let's move on to costs. Question here is, well, what costs should we include? How do we obtain costs? And what other issues should we consider? Well, there are 3 stages to any costing. The first is identification. That is, what resources are relevant to a particular intervention. So by resources here, talk about it the next page, but we're talking about how many clinic visits, how much time spent with a nurse or a clinician, how long in hospital, how many drugs, how many tests. So they're the things we're interested in. We then need to measure their volume of use. So how many of those things? And then we have to put a value on them. That is, what is the unit cost? What is the price or financial cost associated with a unit of the resource, a day in hospital, a visit to a clinic? And that we can express financially, or we can express in terms of opportunity cost. So when we're thinking about identification, we need to list some of the ingredients, if you like, in delivering care. It might be nursing or medical time, drugs, equipment, but we need to think about whether we're only interested in the budget of the health system. So in reality, the delivery of healthcare consists often of impacts on a range of different budgets. And so the perspective of the analysis, that is whose budgets we're interested in, becomes really important. It's important also to report both the quantities of resources that a particular intervention and its comparators uses, as well as their price or unit costs. So this issue of whose costs to include does depend very much on viewpoint. So are we interested in, for example, the viewpoint of the Ministry of Health, the healthcare sector, the hospital, or is it broader? Is it the society itself, which would include patients, but could include other considerations as well, like impact on productivity? Sometimes we can simplify costing analysis if the alternatives we're comparing, say 3 or 4 drugs for tuberculosis, have common costs. If certain things are common to all our comparators, we don't have to quantify them. And then we need to think about what are the most important costs. Sometimes, things are likely to differ to such small margins between our comparators that we can deprioritize them. We need to be interested in the most important differences between the options we're evaluating in terms of costs. So obviously cost analysis is really important. We need to make sure we separately report unit costs and resource quantities, but the precise methodology we use will depend on the sorts of data availability we have. For example, if we are attaching a piece of economic evaluation to a clinical study, like a randomized trial, that gives us an opportunity to collect data, not just of a clinical nature, but also resource use. We can collect, as part of the clinical study, things like visits to clinics, visits to hospitals, drugs consumed, tests used, and so on. But the costs of those resources will vary by local setting. We can't use unit costs from the USA, for example, if we're doing a piece of economic evaluation for Bangladesh. Those costs have to be suitable for the system. So let's go back to the third question I posed, which is, well, how do we make decisions in the trade-off quadrants of this diagram? That is, the top right, where the new treatment is more costly and more effective, and the bottom left, where the new treatment is less costly and less effective. Well, key to this is the concept of opportunity cost. And this diagram, I hope, illustrates what we mean by opportunity cost more fully. If we have a new treatment that costs $1,000 more than existing treatment, so that's an incremental cost, an additional cost. The old treatment is at the origin, so the new treatment has an additional cost of 1,000, but it generates 2 quality adjusted life years. So every additional QALY costs us £500 on average. So we call that the incremental cost effectiveness ratio, the ICER, the additional cost per QALY, per additional QALY generated. That is 1,000 over 2, £500 per QALY. The question is, that $1,000, that $1,000 has to come from somewhere in the system. It's additional. We have to find that by doing less of something else. So we need to know how much health the system will have to give up to find another $1,000 per patient. So this measure of opportunity cost, which we sometimes call the marginal productivity of the health system, can tell us how much health is associated with effectively reducing $1,000 of expenditure elsewhere in the health system. Now, this will be multiplied over how many patients it relates to, but that function, if we read across, tells us something about the health we forego for other patients. And if we then compare the health gain from the new technology, that's 2 QALYs per patient, with the health we forego because of these additional costs, forcing other types of patients to lose health, and that's 1 QALY per patient, then we've come up with this concept of the net health benefit of 1 QALY that I introduced earlier. And we can conclude that at that cost, this technology this intervention, this treatment is potentially cost effective because we get more health, 2 QALYs per patient, than we have to give up in opportunity costs. Compare that with the treatment that costs, if now the cost of the treatment is an additional 2,000, we're still getting 2 QALYs more per patient in terms of benefit, but the opportunity cost is exactly the same, because at $2,000 additional cost, the system's opportunity cost or marginal productivity tells us we're having to give up, through reduced health of other patients, 2 QALYs per patient. So there is no net population health gain associated with this new treatment at that cost. And then let's look at a third situation where the cost is even higher. And now, because of that additional cost of $3,000 per patient, more than existing care, the opportunity costs for other patients are higher. They're 3 QALYs per patient treated, which means we actually have a negative net health benefit associated with this treatment. And we should not fund a new treatment that actually results in a reduction in population health. So this measure of opportunity cost is obviously crucial to understanding how we make decisions in the top right-hand quadrant, and they apply exactly the same in the bottom left-hand quadrant as well. So there is a major question about where does that information come from? Now, for many years, there's been a lack of research on this, and so what tends to have been used in health economics has been sort of ad hoc rules or ad hoc suggestions of what the what have often been called the cost effectiveness threshold should be. So the WHO, for example, for many years linked this metric, this quantity, to the GDP per capita of a country, and used the rule of thumb that between 1 and 3 times GDP per capita was a suitable so-called threshold. The problem is that that position had nothing to do with the health system's marginal productivity and therefore had no relationship with opportunity cost. What we need to do is to understand how productive a healthcare system is, given the resources it has available. And there is now an extensive literature on these estimates of marginal productivity. And this is work that was done back in 2015. There's more recent work of this nature across a whole range of different countries, in this case, low and middle income countries, using globally available data on health outcomes at population level and health budgets as well. And you can see here that these measures of opportunity cost for most of these countries are below 5,000, most of them below 10,000, 1 or 2 between 10 and 15,000 pounds. And this is per DALI avoided. And just to show how these relate to countries' GDP per capita, you can see that most of those countries have measures of marginal productivity below 1 times GDP per capita. And you can see actually Bangladesh is down there as well amongst this group. And so nice that the WHO's guidance over many years that somewhere between 1 and 3, that is between these 2 straight lines, was misleading and indeed profoundly damaging to health systems, because the vast majority of systems could afford much less in terms of additional costs to generate health, because the opportunity costs of those additional costs, that additional expenditure, were much higher than the WHO's guidance, which now thankfully has been withdrawn, implied. Okay, so just to finish off, just to summarize, resource allocation decisions are always needed and are always taken. In other words, because of resource constraints, health systems always have to decide how to spend how to use their available resources appropriately. Sadly, most of those decisions in the past, and indeed still the case in many countries, do not use formal evidence to inform those decisions. An economic evaluation is essentially the set of tools we have available, working very closely with other types of evaluation, particularly clinical evaluation, if we're talking about medical treatment. This is the sort of evidence that healthcare systems need to make better decisions about resource allocation. And those decisions have to be taken locally. It's extremely challenging to define this at a regional or even a global level, because so much of what matters in terms of the value of different interventions and policies depends on local costs and local opportunity costs. We've talked here about some key concepts, in particular, the comparative nature of economic evaluation. We have to compare, we're looking at new treatments or policies, we have to compare those with alternatives. We have to think very carefully about what outcomes we're interested in and how those relate to the objectives of the healthcare system. We have to be systematic, but also mindful of data constraints when we're estimating costs. And perhaps most fundamentally of all, we need to be able to understand conceptually and empirically what we mean by opportunity costs. Thanks very much. I am very happy to take any questions that you might have for me.
Thank you, Mark. It's been a fantastic session, and I'm sure that a lot of early career researchers like me, they have lots of confusion on these basics, and the last session actually just helped us to clear our concept. So the floor is actually open, and we would like to request our guests to ask some questions if they have any. And also our text box is also open. So if you want to put your question in the text box, you can go ahead.
Don't be shy, folks. There are no silly questions. So please fire away anything you're uncertain about, anything you've
Hi, Mark.
good about. Hello. Hello,
How are
Steve.
you?
Very well. Very well.
Yeah, thank you so
That
much for
office looks familiar.
yeah. I was waiting because your time is very precious, I know. So I would like to thank you because it's a very nice presentation. I believe that it will help the people who are working in this health field. And yeah, I'm privileged that I can hear you in person, but those who are here, I'm really requesting all of you, if you have any question, you can ask. So I just want to share one thing with you, that is regarding you, as you say that in order to find out any treatment effect, we have to identify outcome variable first. So I just want to know that what is your suggestion regarding this? That is it okay to find one outcome variable, or more than one is fine as well? So from the literature, I have seen that it's both way. But what is your suggestion regarding this? Thank you
Sure.
so much.
So I think there are some important distinctions to make here. So for decision making, which is really what I've been focusing on, the use of economic evaluation to make better decisions. Ultimately, we need a measure of health that we can compare across different types of treatments and interventions and policies. And that's why I linked it so clearly to a system objective of population health. Now, that's really important to get to ultimately. However, when we're evaluating very particular interventions, very often it's extremely difficult to get data, outcome data, in terms of patients' health outcomes. And we might, for example, use what we sometimes call an intermediate outcome. And in clinical terms, it's sometimes called a surrogate outcome. So in the tuberculosis example, new drug for tuberculosis, the outcome measure in the clinical studies might be a cases cured, for example. We then, as economists, have to think about how we link the intermediate outcome to what we might call the final outcome, like a QALY or a DALY. And that's where often we can use more secondary sources of data to help us. So we might be able to find in literature something that tells us about what the impact on life expectancy and quality of life associated with curing tuberculosis is. And so we've got some very specific data from our clinical study about cases cured from this new drug, but we can use more general secondary sources to help us translate cases cured or additional cases cured into gains in QALYs or reductions in DALYs. And that also applies when we talk about what's sometimes called program evaluation, which is more about policy evaluation. It could be a new program of prevention, or it could be a new insurance scheme, even within a system. In those situations, directly measuring impact on patients' health outcomes is extremely challenging. But again, the principles are the same. We need to understand something about intermediate effects, and we might be able to use some quite sophisticated methods, econometric methods, for example, to do that. But they do ultimately have to be linked to measures of outcome that allow us to compare value for money with other things. So that's the challenge.
Yeah, thank you. I think it will help.
Thank you, Mark. I think we have a question in the text box. Mark, do you want me to read that out for you?
No, I can do that. This is from
Saifi.
Saifi, yeah. If we're providing any certain intervention which don't have any particular clinical outcome, rather than focus on behavioral knowledge change outcome? Would it be possible to generate future costs if that intervention was not provided, and the cost effectiveness of that intervention? So I think the question there is then, when the intervention is not focused on outcomes, it's focused on changing behavioral knowledge. How do we evaluate those interventions? That's what I take the question to be. And I think, I mean, ultimately, it partly depends on what health systems are trying to do. I think most sort of, if it were an intervention to change behavioral knowledge, I'm assuming in most situations, we are ultimately trying to impact health outcomes because of that. But through that change of behavior, say, we want to change people's health outcome at some point in the future because they behave differently. So we have a big problem of obesity in this country, the UK. So changing behavior with respect to food is something that we're often trying to achieve through public health interventions. Now, if we can show that evidence, just a change in knowledge or change in behavior, and we can also show that that whatever that program is saves money, then we may not need to know what the ultimate impact on health outcomes is, if we can assume that changing knowledge and behavior is a good thing, and we can show it saves money. But generally speaking, you can only show that it saves money if you understand something about how it will ultimately impact on health outcomes. So again, we need to think about types of evidence that can help us link a change in behavior with a change in outcome. So if that were dietary behavior, the obesity example, then we need to understand how long would it take for that change in behavior to manifest itself in terms of reductions in BMI and obesity, and how long would it take to impact on patients' health, for example, reductions in diabetes, cardiovascular disease, and so on. So those types of evaluations can be more challenging, but a lot of them have been done before. So seeing what other people have done internationally and establishing what evidence can be translated from that sort of international literature to the particular setting you're working in is a really important part of any economic evaluation.
Thank you, Mark. Thanks, Saifi. I hope that answers your question. And just being, conscious about our time. So we are already, crossed our time for the planned webinar. But we can upload this lecture on our HERN website, and as well as we will have all of your, email addresses and our respective, guest email addresses. So you can always reach to us with your questions, and we will try to, make you connected with our speakers and guests, and as much as from our side possible. Thank you, Mark. On behalf of HERN and ARK Foundation, I'm appreciating your presence and your kind contribution to this platform. We look forward to hear from you again in future, and we believe that she will definitely help us to get some more diligent speakers from this platform, and at the same time enlighten us with their work and with their contribution in the particular field. We would like to request our guests to access our website as well as our Facebook HERN page to get the regular updates from our platform, to know the events which are upcoming. And obviously we believe that with all our support and with all our cooperations, we will move ahead further. Thanks, and wish you all very good very good time ahead, and enjoy the rest of the day. Thank you so much for joining.
Thank you. Thanks, everyone. Bye-bye.